thank you so very much for taking the time to meet with me today. I am honored to have you. I'd love for you to share your background in working with vulnerable and underserved populations.
It's a pleasure to do this. So I have been working for a long time in mental health, healthcare, and social services, well over 25 years at this point. I have worked with all populations from children and youth, families, and then now in the last 8 years with adults. And specifically, I have worked with populations who have complex behavioral health, medical, and social needs, all of them across the life spectrum. I was fortunate to be part of the beginning of 2 innovative models for care, one for youth around supported employment program. I began that one in 1988. And then another one, which was a wraparound program for children with severe emotional disturbances to help their families. And I was with that program for about 12 to 15 years. So wonderful experience there. And what I learned from my first 20 or so years of work is that I really wanted to advance changes on a policy level for larger populations across the state. So that was specifically why I went back to get my doctorate in healthcare policy. And I got it from the Heller School at Brandeis University. And their motto is knowledge advancing social justice. And that is exactly fits my passion because the populations that I have served, as you said, are not only vulnerable, but in most cases they have been discriminated by the healthcare system, by society many times. There's a lot of stigma, as people know, around mental health problems. There's a lot of misunderstanding about what it is to struggle with a mental illness. And this population can get categorized in ways that are disrespectful. And when you categorize people who are struggling with legitimate disorders, we just can't see them because they're in the neurophysiology of our body. So you can't see the broken arm, you can't see a broken heart, you can't see somebody's psychosis, right? You only see behavioral manifestations, and when you can't see it, you don't understand it, and they can be misperceived and mistreated. So currently I'm working with the state in its transformation through a 1115 waiver with the Centers for Medicare and Medicaid Services, specifically to change the delivery of care and the payment of care for adults who have chronic and complex medical, behavioral health, and social needs. So it's very exciting. It is classic care coordination, and we are charged to find a very, very vulnerable population, a very expensive population, and find them, engage them, and get them connected to healthcare and behavioral health care and what resources they need from social services and the community so they can be healthier and live more stable lives. So that's where I am now in my journey.
Do you see telemedicine playing in care coordination and improving health outcomes?
Telehealth and electronic means of safely and securely sharing information about patients in real time is critical in care coordination. And healthcare and electronic communication and EMRs, electronic medical records, are already inextricably linked, right? They're already linked because we have EMRs, right? I think it's really critical because it's one more tool that we have in order to connect with people in real time to get them the help they need in real time, right? And especially, I think it's really especially important when you're dealing with people who have not been well served by the system. And you're coming in and saying, well, you can trust me. I don't, don't worry about what happened in the past. I'm good. And if you have to be able to prove that to them. right? So I'll give an example. One of the things that we have in Massachusetts is a number of different platforms that function as an event notification system. And in an event notification system, we get, because all of our people are imported up to the cloud, if you will, to the event notification system, that whenever somebody enters an ED, within 3 to 5 minutes of being registered, we get a notification. Our care coordinator, our clinical care manager, and our nurses get an email notification that says Deborah Jean Parsons just hit the ED. And it says whatever the presenting problem is or diagnosis. Then in real time, I know, well, geez, my member that I'm working with is in the hospital. I know why. We reach out to the hospital. Can I talk to them? Can I talk to the charge nurse? Can I talk to the social worker? I'm working with this person, and this is what we're trying to help them with. Then we can become part of discharge planning, and then we're responsible for the aftercare. So if I didn't have that information, how would I know? And by the way, a lot of the people we work with, they're not going to call us first before they go to the ED. Or when something happens and they end up in the ED because they fell down unconscious, they're not going to know. So it's just one example of how we can provide the care, the coordination of care that's needed between what's going on outside that hospital and what they're trying to do in the immediacy of treating that person within the hospital.
I'm curious because when we speak of underserved populations, these are people who have historically been neglected, injustices of inequities, this health disparities, all of these things are happening. Who do you see as playing or leading the charge in terms of healthcare post COVID-19 pandemic? Is it policymakers? Is it the patients themselves? Is it the healthcare system? Who should be leading this charge?
So that's a $64 million question, Christine. I think we're all in this together, let's be honest. And that's one of the things you learn about with care coordination. Everybody plays a role in making sure that somebody is getting the care that they need, whether it's the primary care doctor or the psychiatrist, and they both need to know the meds that the person is on at the same time, to knowing somebody's positive for COVID-19, right? And now even more important, who did that person contact with and who's vulnerable? So I would say that from my experience, what we've been seeing from our program and in the state of Massachusetts is it has been Medicaid, which is called MassHealth in Massachusetts, has taken the lead in this. But for the Centers for Medicaid and Medicare Services have helped as well, easing regulations on the ability to provide telehealth. The ability to use text as a viable, legitimate form of communication with somebody, relaxing on requirements that you have to see somebody face to face after a hospital discharge or after an ED visit, that can be done telephonically, and you can use telehealth to do that. That's been critical for us to be able to continue to provide the care that we need to for people at a time where they really do need continuous care. We can't just stop working, right? Because of this, but we have to do it safely and securely. And this is where I think telehealth and telecommunications is key for us at this time. So I would say absolutely the policymakers are part of this. They have to be, because there are rules and regulations, which is what policy is, right? There are rules and regulations that have to be able to provide that access, okay? And then the payers to pay for it, which is part of the rules and regulations. And then I think that for most people, the patients are willing to communicate with us in any way they can. They don't have a laptop, obviously, they won't be able to do what we're doing right now. But texting and telephone, we had somebody the other day who said they had an hour conversation with somebody that used to just be like, yeah, I'm fine, I don't need anything. But they're so lonely, they feel disconnected, and their care coordinator calls them and talks with them for an hour on the phone every week. And guess what? That's what they need, and there we go, we can do it.
I love that you shared that, because my next question was around people who may not have access to you, or the services that your company provides in their tool bag. how can those people essentially advocate for themselves to continue to receive care as we're going through a pandemic and a public health crisis?
Yeah. So there's two sides to that. The first side, I think, falls on us as a healthcare system. You know, we need, I mean, if we've learned anything from this COVID-19 crisis, we have to look at everybody in our population. Everybody is vulnerable. If you're not vulnerable to get it, you're vulnerable and you're giving it to somebody else, right? So we have to make sure that our population we're serving, whether it's your patient panel as a doctor or like us, our program and who's in it, even the people that haven't said, oh, I'd love to be in your program, we're still calling those people that used to blow us off, or, you know, because we need to connect with them however best we can, at least try. So it behooves the healthcare system to reach out to the population. Again, you can tailor how you do that based on the needs, and what is working for a particular population, but it's more important now, right? Then on the other side, I would say, um, because of the opening up of telehealth, there are more ways for folks to reach their doctor. It is difficult if doctor's offices are closing and well, they close their doors, they're moving all to telephonic. So as much as you can do by phone, and there are a lot of opening up of extra lines in doctor's offices, nurse hotlines, hospitals are opening up as well. So the system is trying to open up that access point for people to come in, and then us who are on the inside and have people on our panels, we need to be doing even more assertive outreach to them in any kind of way that we can get telephonically. And we use mail, we use texting, we call, and if we can video and conference with them, we'll do that as well.
What would be your call to action to society, to our government, to our policymakers, to payers, providers? What is your call to action?
Well, I think I have two. One involves telehealth, which is now that we've experienced what is possible. I mean, the silver lining in this crisis, one of them is that it has propelled telehealth to the forefront, and legitimized it, that this is a service that can be paid for, and it doesn't work for everybody or every situation, but for when it does, and we can meet like this and get somebody the care that they need, whether it's a script or whether it's a referral for something, then let's use it. So now would be the time to look at your own system. How can you advance telehealth within your own system? What do you need? Who needs to get more education and more training and more comfort level on using telehealth? I think that's one. The second one is, more so than ever, I think this is a challenge to the healthcare system, which has acknowledged this already. Any redesign efforts from the healthcare system need to include the financing structures for care coordination. If you don't finance it won't happen. MassHealth is doing that now. They have put money into the community partner program to pay for care coordination for this population, because if you don't pay somebody to do it, you don't give it to them as a responsibility, it won't get done. So I think that's really critical. And the more that we can find states adopting health homes, which we have, I think last count was about 20 now in the country that have them. MassHealth, we have our community partner program. The more that we can be financing this kind of work, the better we're gonna serve our populations, and I might add, reduce the cost of healthcare. These are the most expensive patients in the system. They're the most needy, and when we can help them, it's a benefit for them, it's a benefit for us, and it saves us financially from our expanding healthcare costs in this country.
Final thoughts.
Oh, I don't know if I have any final thoughts. The work continues. The good news is that through the ACA, more and more states are running demonstration projects. They're doing through the waiver. We have the expansion of health homes. And I think the more that we work in providing that, across our country, I think we'll start to see some better outcomes for some of the most needy people and lessons learned that can be applied for any population.
Dr. Parsons, I am so very grateful for this opportunity. Thank you for sharing this time and sharing your expertise. It's been such a delight.
Well, it was absolutely so much fun on my part too. Thank you, Christine.